Hi everyone, my name is Ravleen.
Hello guys, my name is Prabhnoor.
So, a little bit about me. I'm a fourth semester nursing student or incoming fourth semester nursing student at Fresno State. And I'm interested in becoming a CRNA. And I've started this podcast to gather professionals and just talk about diversity and other topics in healthcare that may not be discussed elsewhere.
Okay, and then I'm Ravleen once again, and I'm a pre-med student. I graduated in 2023 from UC Merced, and this is my first time doing a podcast.
What made you want to go into the pre-med field?
Yeah, so growing up, I've always gone to medical offices with my parents, and then I was always their voice. And it was for my younger siblings. My parents never went to the doctors. And I feel that's when I decided that I wanted to go into the healthcare field, but I never, I didn't know what it was. And then growing up, in like Indian household, Punjabi household, like your parents are like, oh, you're gonna be a doctor. And I was like, okay, I'll explore that.
My parents were the exact same. They were like, "Oh, you're gonna be a doctor," but then I figured out that there was a residency, and then you work 70-hour weeks. And I was like, "Oh, maybe I don't want to do I don't want to be an MD. It'd be cool to have MD after your name, but I
Yeah.
figured I'd rather do something that I was passionate about." And then throughout nursing, I discovered CRNA. Actually, I knew about CRNAs before nursing school. I first stepped into the field right when I graduated, actually. So when I graduated, I went into pre-nursing and I was just taking these classes, these um, pre-nursing classes, which consisted of chemistry, biology, and we were talking earlier about dual enrollment during high school, which is
Mhm.
something that I really emphasize to people that are coming in. Do your dual enrollment classes, because if it weren't for my dual enrollment classes, I would have fallen behind a semester because I didn't have a biology class in my first semester of college, if that
Mhm.
makes sense. Because in order to take certain classes, you have to take certain classes prior, so it just puts you ahead if you get those introduction classes out of the way.
Yeah,
Um,
that's something that I did push like my younger siblings because I'm the oldest. And during my time, it was always like, oh my God, take so many AP classes and that's what matters. And then your extracurriculars, like, I don't know, joining clubs, just volunteer hours. But I really wish my high school had more like dual enrollment and didn't make it so hard. But right now, I do think it's easier for kids, students to do the dual enrollment program. I
yeah,
feel like
and
it's more.
it's really great we started off with high school because that's really where most pre-med start and most like pre-nursing students start. It's during high school they get an idea of what they want to do, and like if you take the paths where it gets easier for you later on, you're just on a really like awesome trajectory. And well, the thing with AP classes is you have to take a test at the end to prove that you're going to get the credits or not, which I think is a really not good system because for one, some person may have test anxiety, etc. And then two, if a person scores an A in the class, does all the classwork presentations, does that really dictate if they can pass a test or not? I don't think it's like a good measurement of it. But if you're taking dual enrollment, you're taking actual college classes, regardless of if you get an A or B or a C. You'd
Mhm.
want to get an A if you're a pre med, but that's the goal for everyone, I guess, or not. But yeah.
Yeah. And no, it puts so much like stress on like a 16-year-old or like a, 17-year-old. And that's
Mhm.
when it doesn't add any value. I guess it does just for your GPA, but I know people that did dual enrollment and they were able to graduate in like 2 years in college. They were
Yeah.
able to finish everything and then take that gap year.
I am a incoming P1, so incoming PharmD student. So I'll be doing my doctor of pharmacy at UCSF, and I just graduated from UC Merced this past December, 2023. So I did public health, so not the traditional human bio or like chemistry and stuff like that. So I was public health, a little bit different, but
What made you want to go into what made you want to go into the field that you're currently interested in?
So I was deciding between, like medicine and pharmacy. So my first year I was pre-med, and then I was like, okay, I'll, take the basic pre-med classes and whatnot. And then after that, I worked. Oh, I need to go pick up my medicine. So Merced, it's kind of rural. It's the Central Valley, right? So I need to
Mm.
go pick up my medicine for asthma, and I had an asthma attack. I've had asthma since birth, but in like the Bay Area, it hasn't acted up. But there, it was my first year, and I need to go pick up my inhalers, which I haven't used in a super long time. And I was looking up, 24-hour pharmacies, and the closest one was either in Fresno, like 55 miles away, or all the way in Modesto, which was like another 55 miles away. And I was like, whoa, like if there's an actual emergency for someone like the middle of the night, like what would they do? And so that's like kind of the leading factor, what made me, or that was like the start of it, I guess, that made me go into pharmacy. And then after that, I through like BIPSI clinics and all that type of stuff, I realized how important medication literacy is. And I realized that, like our community, especially like, the brown community or other minorities, they don't realize what their medication is doing for them, or they don't realize the side effects. They're kind of just, throwing it in when they need it, or sometimes they'll skip a dose, or sometimes, they'll take one. So I was like, I want to focus more on like the treatment aspect rather than, like diagnosing and then not following up with the patient, if that makes sense.
Yeah, and it's funny that you mentioned that our community has people who take medications certain days, and then the next day they just feel like not taking them anymore. And I guess an example of this is like their insulin. A lot of people have diabetes. And they're like, "Oh, minuas haros nani pogi." Like they're not sure that they need to take it every day or not. They take it optionally. So that's one thing I feel like the language barrier is important. And tying that into what Ravleen said about her volunteering, I had a SINA clinic or SINA mobile health unit that we did at Basaki Mela, which is like a get together at our church, and it happens once a year. So I guess you can call it a like what is that thing where you call what are the pumpkin patches? Like you know how you go to like a pumpkin patch yearly? What is that called? I'm blanking.
Like a carnival?
A carnival, yeah. It's exactly like a carnival, but it has carnival rides. You can't really call it a carnival because it's like
Yeah.
religious as well. But it does showcase like some of the cultural stuff, like cultural dances, which we call pangra.
Yeah.
And we had a mobile health unit there, and we had a bunch of elderly people come by, and it was funny because they had their they ate sweets there, so they would come right after to check their blood sugar, which is kind of funny and kind of cute at the same time. So there's definitely that language barrier, which contributed to the gap in education that we were able to fill, I hope, that day. And I had a older gentleman come in. He had a higher blood sugar, and he's like, my blood sugar never gets this high. And so just explaining the differences between what a blood sugar test is, like a finger stick test, and what an A1C is very important in that regard. But yeah, Ravleen, could you also share that experience that you talked about earlier?
Yeah. So like volunteering with Jakarta, they have the medical school, the DO school, CHSU, and they also have UCSF that bring in their mobile clinic. And then it's funny because to get started, like we have to push like a lot of like BBs and babas, like like, hey, come get your blood pressure checked, like let's just get it done. They're like, oh nahi, like main cha piti hai, like oh main kha ke aayi hu. But like, and then some of them are like too excited. They're like, oh, just check, and then like people like my grandpa, they're coming like, oh, mera blood pressure nahi na high hundega, and they're like, oh, like thoda blood pressure high hai. He's like, oh, it hunda hi rehda, but like when I check at home, it's like normal. And
Yeah.
and like I wanted to add, my grandpa does not take his blood pressure medication like as he should, but when we sat him down, and even his cardiologist, he was like, what's the use of you not taking these medications if you're not like, what if something happens to you? You're going to end up on these medications anyway, so might as well just start taking them. I feel like you have to be very like stern with them. Otherwise, they just, a lot of they just humor it off. Like, they just laugh it off. Like, oh, nothing's going to happen to me. I take like, I don't know, like haldi dud or something. I don't know.
Yeah.
Yeah.
I want to go into that because when I was younger and I was a chubby kid, so I used to be like I'd say like 240 pounds or something in like in middle school. And what really motivated me was my grandma just calling. She was pretty much fat shaming me, but like in a positive manner. She was my grandma, and I understand where she's coming from. So like I got fat shamed into being like a healthier kid, but I felt
Yeah.
like it was worth it for me. Whenever I would talk to her about like some of the diet choices we made in our household, you know how there's desi ghee
Yeah.
and stuff. They don't think that it correlates with high cholesterol, and that's something that I had to educate my grandma with. So basically, this is like if you guys don't know what this is like cooking oil, but it's like butter extract cooking oil. And pretty much anything butter shouldn't sound healthy because it's coming processed from the store. And there was excessive amounts in it of it in our like vegetables and in something that we eat because most Sikh people are vegetarian, and we usually eat like cultural foods which have a higher content of the extracted butter in it, and that's really not good for your cholesterol as well. And just knowing that and then making those changes and just making those changes would also evidently help your parents have a better lifestyle as well, and not only you. But Prabhnoor, do you have any experience with that as well? Just going back into like filling in the gap for sick people in healthcare.
I guess I could talk about a couple like Bipshi clinics, and then I also worked as a pharmacy technician. And so you'd have a big load of like Punjabi people come in every day, whether they're discharged from the hospital St. Agnes, and they'd come pick up their medication there. If they're just following up, and you'd ask them, "Oh, do you have any questions for the pharmacist, or do you have any questions for that?" And they'd be like, "Oh, nahi, ਅਸੀਂ ਤਾਂ ਦਵਾਈ like, oh, we don't really take it that much." And I was like, "Oh, you fill it every single time?" They're like, "Yeah, we just keep it because we need to pick it up." And so then the pharmacist, I'll be there translating because he was a white Caucasian male, and they couldn't really understand him. And they'd get excited. They'd be like, oh, he'd be like, oh, make sure you take it with food. Make sure you do it with this. Oh, I was looking over your, A1C levels, or I was looking at your LDL, HDL. It's on the rise. You need to start taking your medication. And they'd be like, okay, Hunda. I was like, oh, it's a bad cholesterol that's rising up, or your A1C is your 3 month, blood sugar levels that they average out, and it's showing that you're more than pre-diabetic now. That's why they gave you this metformin, or that's why they started you on glipizide, or whatever it may be. And then they'd be like, "Assi to kuch khande hi nahi mithe wala." I'm like, "Oh, then what do you guys eat?" They're like, "Oh, roti khane ya, chawal kha lene ya, like kha lene ya." I'm like, "Okay, that's carbs, and carbs increase your glucose levels every time you eat them, or you'd have to like provide that medical education. Or I couldn't do it because I was out of my scope of practice, but the pharmacist, you tell them, oh, cut down on your carbs, or cut down on this, or milk is also sugar. Milk increases your blood glucose levels. Let's swap it out with soy milk or something like that. And then, so I guess it's just a whole bunch of education and making sure they understand. And if so, they'll just understand because they have to sign off that they've been counseled. So they'll understand there, and they'll, at the end, they'll be like, oh, but I see dwaiyan to darde hain, side effect bahut hai. I'm like, I think the side effects don't outweigh the benefits of the medication. Like, it's in the long term, it's going to help you out. And then he'd talk to him like, oh, can you educate him about the long term effects of like diabetes and whatever, like what diabetes can do to you. And then they'll talk about like diabetic retinopathy, or leg amputation, finger amputation, and stuff like that. And then they'd be like, oh, sugar and nakosh kar diya. I'm like, yeah, like that's what he's saying. Maybe let's start taking your metformin once a day so it doesn't get to that point. But I guess that's an experience I had.
Yeah, and it's funny that you mentioned the amputation. Well, amputations aren't funny, but it's the way you mentioned it is funny because we during our clinical rotations in a med surg unit, we were nursing students and we're instructed to pretty much do our assessments because that's all we can do during first sem. not really anything nursing care related or anything that's highly advanced. So pretty much we were checking the capillary refill of patients, and some people do it on the hands, some people do it on the feet, and you have to really be careful with the feet, is because with these really diabetic patients, they have like necrosis of the feet. So if you pull too hard, their toe could actually come off. And we had a example of this in our nursing program where it actually happened to someone. So the scare tactic is really something that works, and it worked on me because I comprehended it when I was younger. I went to my pediatrician, and he pretty much told me that if you don't do this, like your arteries are going to start to clog up. And then I went home, searched on YouTube, oh, arteries clogging up, and it was like these scary illustrations of like arteries clogging up and like blowing up. I was like, oh, dude, I gotta get it in control. So like, and that's where my passion for running really started, is because like it's a really good cardiovascular exercise, and you know that's where it all like turned around for me. But going past that, is there any other things you guys are currently doing, like in your profession, to like excel yourself? So I'll give some examples, which you guys can cherry pick or talk about if you want. So I'm currently in the process of using this summer as like a stepping stone into doing more research and just going to more events. Anything that I could put on my resume and anything that can like improve my learning, in terms of applying and going to CRNA schools. Is there something you guys are doing right now that you're currently like interested in, or that's something that you want to share?
I guess I could go first, but I am a medical assistant, so at a private clinic where I get to observe a lot of surgeries, and it's orthopedic surgeries. So I did learn that it's very boring for me. Yeah, it's cool, like a lot. You see a lot of knees, arthritis. My grandpa did have both total knee replacements, and it just shows like these patients are also like very vulnerable, and it's just really nice having like these connections. And then I am trying to get involved in research. San Francisco's a really big city with a lot of opportunities, way more opportunities than the Central Valley, and the change of demographics, which I saw finding like, so I'm in my gap year trying to study for my MCAT and just finding more opportunities. But yeah, go ahead, Prabhnoor.
So I did research, with a public health professor, Dr. Gonzalez at UC Merced. She did tobacco use and the impacts of tobacco use and prevalence rates of like asthma or something like that. So that's what I did research my first, my first year summer. So before going into my second year summer, sorry, I did it my second year summer before going into my last semester at UC Merced. And I didn't really do any hands-on research. I was just kind of there because I guess she was nice enough to let me on to her team. But we would do, biostatistics and get everything together and, help her file her reports and all that type of stuff. But when looking at it, I was like, oh, maybe this is something I could use to when I'm applying to, my programs. And so I did do that because, I put it on my applications. And then I had some work experience. I did a medication technician at a nursing home down in Merced. It was a assisted living facility. I worked there for not too long, but some time. And there, I guess I was basically, doing MedPass and calling the pharmacies, because it was mail order pharmacy, calling the mail order pharmacies for refills and stuff like that. Being there for the needs of the patients, if they need water, or the residents, or if they need water, if they need, a PRN Tylenol, or if they had a fall, talking with the EMTs, trying to make sure they get to the hospital safely, contacting the families and stuff like that. But I'm interested in clinical pharmacy, not so research, community pharmacy, retail. It's not the generic CVS, Walgreens pharmacist. More of inpatient settings, clinical settings, or like AmCare, which is in like a PCP, basically like a primary care provider in clinics, doing like diabetes management or doing, diabetes is a complex problem, so diabetes management still just pharmacists there will dose and, dose insulin for patients because everybody's need is different for how they should be dosed for insulin, and it's hard for physicians to do that solely by themselves. So then you'll have diabetes management pharmacists who will solely just do that. Or but I want to do inpatient, so like clinical pharmacy inpatient, like on hospital wards, doing med reconsultations or like emergency department and stuff like that. And I want to do research at UCSF. Is like San Francisco and the main hospital, UCSF, they're like the research powerhouse, and there's a whole bunch of research opportunities, and I want to get involved with pharmacogenomics and pharmacogenetics, which they'll trace, genetics, and everybody metabolizes medicine differently, and when you'll do, a gene, when you'll look at their genes to see what receptors or what genes they have may have more or less of, you could actually dose the medication based off of that. So there's not a there's not a surplus of you taking that medication, and sometimes you may need more than the dose that everyone gets prescribed. So I feel like that's like the future of pharmacy, and they're hoping to implement that into retail and community settings too. But I'm interested in going in and researching pharmacogenetics. I haven't reached out to any professors yet because we haven't started. But once I'm there, I'll probably try to figure it out and do research with pharmacogenetics.
That's amazing that you mentioned that, because the most I felt like a pharmacist would be in our OB rotations, where we were titrating Pitocin for like, oxytocin and labor contractions. That's the one instance I can remember where we were titrating medications. But I like that you mentioned the research aspect at UCSF. They do a lot of experimental stuff even at their hospitals, because the pediatric clinic or pediatric hospital that I attended clinicals this semester, Valley Children's, it's highly specialized in pediatrics, and recently they announced that they're starting to do bone marrow transplants, but previously they used to refer them out to UCSF or Stanford because they had a higher capacity for the pediatric populations there. And that's something that is really cool, because in the pediatric populations, it's very different from adults. And a difference that I'll get into would be, again, you mentioned pharmacy. It's very specific in terms of dosing and giving those pediatric kiddos like what medications they need to get in a safe manner for them. And yeah, so I would say their Valley Children also has a very good research program there, because it's so specialized in pediatrics. They have a really good IRB. For the viewers that don't know, IRB is the Institutional Review Board, and this is pretty much how the research is being performed with the help of the hospital. And I think it's cool that Ravleen is in like a outpatient setting, kind of, because it's a better opportunity to do your research at that location. A lot of the NP students that go to our school work at outpatient centers, because it's easier to get permissions there in order to perform research compared to getting a permission from a hospital. But yeah, do you want to get into that as well, Ravleen?
So my clinic does have opportunities with surgical research. I have not been involved in it yet, but it's a lot of with different like sutures and like arthroscopic shoulder replacements, and it's a good opportunity. We do get more permissions because I feel like hospitals have to go through, especially UCSF has to go through so much board review and all that, and I still need to explore more. This is my first year living out here, and it's been a really big like difference coming from the Central Valley, like middle of nowhere, to here where there's so many like more opportunities here.
Yeah, and I assume it would be like kind of overloading the amount of opportunities you have, because you don't know where to start, and you don't know where to narrow it down. And yeah, I'd say UCSF and like San Francisco in general, you have a variety of hospitals you can choose from, outpatient centers you can choose from, and that's really good for doing education or doing research in that regard.
For me personally, like undergrad was really hard to get into research because I it was like after COVID, and like a lot of like biology professors preferred like third year students, like fourth year students that already like they knew and stuff, and I didn't have like any connection with them, and I guess I was always like hesitant, like reaching out.
So you mentioned some of like your OR experience, or do you have any OR experience, like shadowing wise?
Yeah, just like shadowing like um knee scopes, shoulder replacements, and yeah, knee replacements.
So when they do these knee replacements, and what kind of and what do you know like what kind of anesthesia is used? Is the patient like fully intubated, knocked out, or are they
Yeah.
just doing blocks?
They do a nerve block in the beginning, and then the patient is completely out. Um, it takes about 2 to 3 hours, depending on the surgeon. And it's actually really cool seeing the nerve block by the anesthesiologist. And you just see them sitting and like, chilling in the back while like the whole, like, our surgery center is like pretty intimate, like small. And so it's very different when I do go into hospitals. They have like a bigger team and like more equipment. It's just interesting to see with like outpatient clinics, like how limited they are with their equipment. And I did actually, like, funny story, like one of my patients was supposed to get an elbow surgery. I forgot what it was, but they called them up. They're like, hey, like, we don't have the part, so we're gonna reschedule you like another time. And then the patient was so confused. He was like, what do you mean you don't have the equipment? Like, do you want me to get it for you or something? And they never called back. And like, you see like this patient so frustrated, and we're like, like, we'll refer you out to like a different like physician.
Yeah. And then I know Prabhnoor said that as well, that he would like to work in more of like in hospital settings, in larger settings. I feel like it's different because of the patients and like the doctors themselves. Um, I when I had my med surg rotations in my second semester, we were at an outpatient clinic with St. Agnes, which is one of our local hospitals here. And pretty much what they were doing at this outpatient center is they were doing like spinal pain relief. They were doing glaucomas and cataracts. And these are same day surgeries. So patients get to go home. And what you mentioned about not having the parts is pretty true, because sometimes they don't have the parts, like the lens for the cataracts. Is sometimes not on back. It's on back order, and it's more. It is more intimate because one, the ORs are smaller. The nursing team is smaller. Everything is pretty much on a smaller scale compared to larger ORs. I mentioned before Valley Children's. Valley Children's has super gigantic ORs where they have the doctor work on the discharge right when surgery ends. They have a large team of professionals, so they have something that's called a first assist nurse. And pretty much this nurse is allowed to, be hands-on with the surgery. And I'm not too familiar with it, so I can't speak too much about it. But from the surgeon, I heard that they're allowed to, or from the first assist nurse, I heard that they're allowed to do most things except start the initial insertion or incision. And I felt like that's a pretty good career to also go into. If I wasn't going into CRNA or the CRNA route, I would definitely look into the first assist nurse route. And that leads into my next question. Is there anything else besides the careers that you're in that you guys consider doing?
Yeah. I like, okay, so something that I do want to do like on the side or like be really involved in is like policy making, especially health like policy. Like that's something that I feel like I was always passionate about. And then an undergrad joining Jakarta movement, and that's like it opened up my eyes like how much of an influence our government like has on these policies and what they could influence. And something that me and Prabhnoor got involved in was like in Livingston, Merced area. It's very small and like very like they're not looked into. They're very, you know, they our hospital is like run down in Merced. It's very sad because you have to drive either 50 minutes to go to CRMC in Fresno or a hospital in Modesto.
I guess I would. So I was pre-med, so I was thinking about medical school and like being a physician, and that's what I guess the gold standard was. And like coming from a Punjabi family or a Punjabi household with all my cousins and all my family doing pre-med, or some of them are NPs right now, or PA, physical therapist, and all that type of stuff. So it's always, I knew I've been, like, I guess not even, it wasn't even forced. I knew I had a passion for medicine and helping people out and making people, feel better, or like in the healthcare field completely. But I guess first I was, retail pharmacy, community pharmacy, because they're the most accessible healthcare provider out there, or healthcare professional out there. Like you can walk into any, now big box stores or big chain stores, and ask them a simple question like, what allergy medication is best if I have, high blood pressure? So I was more intrigued of like the fact that, like this person can help someone out, like, so fast and so quickly, and like a small pill makes such a big difference on someone's body, and potentially sometimes it's like the thing that's keeping someone alive. But then, like Ravleen said, health policy. I figured public health. I was a bio major, human bio. I guess it was the biggest mistake I made for my first semester, or semester being a human bio major, almost ruining my GPA if I stuck with it throughout my undergrad career. So thankfully I switched into public health, and in public health I wanted to do an MPH, or I still want to do an MPH with the MBA, and do healthcare policies and work for healthcare reforms. Something that I got quite involved with was the Madeira General Hospital, or community hospital, shutting down. And like Ravleen said, now like the communities of Chowchilla, Madeira, Livingston, Delhi, and Atwater, and Merced, like the closest hospital would either be CRMC in Fresno, or doctors in Modesto. And then there's Emmanuel in Turlock, but that's like a small community hospital. So I guess another career considered was like policy reform and working as a health policy analyst, and helping change those policies and healthcare policies to have better access into healthcare. Because insurance companies, even working as a pharmacy tech right now, insurance companies, they all they care about is the money. They don't care about health. The well-being of the patients. They just want to see how they'll maximize profit. In pharmacy, there's a big thing there called PBMs. If like the viewers don't know, PBMs are pharmacy benefit managers, and they've wiped out independent pharmacies as a whole. So these small chain pharmacies, independent pharmacies, are like private pharmacy owners. They've been knocked out by these PBMs working for CVS and Walgreens and Rite Aid, and like these big chains that we're all familiar with. The PBMs, basically, they negotiate contracts with insurance companies, and they negotiate contracts with the manufacturers. So big pharma, they have a big hand in big pharma, and they'll basically be like, we'll get the medication from insurance for this much, so-and-so, like, amount of dollars, and then we'll get it from insurance. We'll be like, this is what we authorize, and they'll negotiate with the manufacturer, like, we'll get it from you, and so. And it's usually a really low amount that they get it for, but they'll like bill the insurance, and they'll take a copay of like $120, and the insurance will pay like $700, $800, and which is actually absurd, because if you don't have insurance, there's no way that you'll be able to get access to these medications that you may need. And a lot of people will fall into medical debt, and a lot of people will fall into, like you can get a treatment in a hospital, but to follow up that treatment with a lifelong course or a long-term course of a medication, like there's no way you could pay $700 every single month to get, your supply of medication. So I feel like that's really messed up, and like hospitals shutting down and these small independent pharmacies running out of business, and these small doctors running out of business and having to join these bigger corporations. Like in the Bay Area we have Kaiser, and so like some of these doctors are closing down their practices and having to join Kaiser, and like the big or big corporations, big medical corporations, just because they can't run without having a profit, or they can't run without them making enough money. So I guess our healthcare system, it's ruined. It needs a lot of help, and it needs a lot of reform. So I'm still passionate about that. Maybe down the line I'll go get my NPH and MBA.
I was gonna be like, yeah, like I've seen like patients be so frustrated with these insurance companies because they're like, oh yeah, we'll cover this much, but then you end up getting like a $300-$400 bill at home, and then I think that's where most of like patients like fear comes. Like, how do I decide like to put like my next meal for my children, or do I decide like to keep up with my health and like get my medication or get the help I need so I could keep working. And going back to like the Punjabi community, the Sikh community, we see like a lot of like our elders work so much until they're like all like broken, and then that's when they like have to get help, and that's when like they're at their worst state. And I feel like that's when like the bills pile up, and then that's when I've seen like patients break down because these insurance companies aren't helping. And then sometimes when patients are also under workers' comp, I feel like that's when they're the most frustrated because they don't cover half of these like physical therapies or medications, and then they have to go through this whole loophole, and then sometimes these patients don't end up getting the help that they need.
Even shadowing in like these big children's hospitals, you see how, because once you're in the hospital there's no like, oh, I can't pay, let me get out, or it's like you're gonna have to stay there for your course of treatment. And afterwards you'll see these parents, or you'll talk to the parents when it's discharge time, and they're going over medication education and counseling them like on this medication. They'll break down because they're like, oh, I'm more worried about the $20,000-$30,000 medical bill that I'm gonna have to pay off my co-payment, because insurance will pay like 200. Personal experience too, I had a surgery and insurance paid like 240,000, and it still left my parents with like $30,000. And this was considered like a good insurance that we they pay a really high monthly deductible for in every paycheck that my parents get. But like even in a family practice, like I'll hear my cousins talk about it, like their physicians or their PAs. My Bobby, she's a PA, and she was talking about like a individual Punjabi patient who came in, and you can't directly, even if she was like, I knew he had a sciatic, like nerve pain, and she was like, I couldn't get an MRI because standards of her clinic were like, oh, first you have to send him to physical therapy, and then after physical therapy fails, then you have to send him to this, and after that fails, you have to send him to this. Simply because insurance companies and clinics, they won't pay straight for you to go get an MRI, right? They'd rather wait for you to suffer before they'll send you for like an MRI or even any procedure. So
Yeah.
it's kind of like adding on to what Ravleen said, like it's a whole mess, like a physician could know that this is happening, or like a pharmacist could know like, oh, this is a problem, or any healthcare provider could know that this is a problem, but they can't do anything about it because they're tied, their hands are tied with these insurance companies who won't let them let the patients have these procedures, because then they'll be swamped in a huge amount of debt if like they go without going through their insurance.
Yeah, and that's something that's really an issue with healthcare. I'm not going to mention hospital names because I go to these hospitals, but essentially they don't turn down anyone at the ER or the emergency room. Triage just sends them in, and it's because if they admit the patient, even if there's nothing wrong with them, they could charge them for the services, like, even administering like vaccines. They could charge for that. They could bill the insurance. And so, some of these even procedures that are elective sometimes get forced on because the hospital again can make money from this. And where I think the individual comes into play is, nurses, especially doctors. Doctors can advocate for a patient to get a referral for a similar medication that's maybe costs less for the patient. I know our pharmacology professor mentioned this before as well. There's something that's called the gold standard in pharmacy, is where an original creator of a medicine can have their formula, and then after a certain period of time, after profits are made, other companies can copy that formula and charge people less for those. And so what providers would do is, they would assign their patient the version of the medication that is less expensive to help out the patient. But there's only so much that a physician or any individual can do. It's where you really have to get into those advanced political roles to make a difference.
Yeah, yeah, yeah. So like insurance companies or Tylenol, they have like a patent, and the generic or the brand name even working in like pharmacies right now currently as a tech, like the brand name medication is like far more expensive than like the generic name medications. And like seeing these big institutions, and like seeing what goes on in these big institutions, like the more you bill for, the more these physicians bill for, the higher amount of bonuses they'll get, or like something like that, or simply the facility will lay them off, or the facility would like make them do the grunt work because you're not billing a certain amount of money for the hospital to make profit. So yeah, so that's just like another thing.
Yeah, and I also want to add something else I currently thought of is, hospitals are doing another profit slash thing for the patient. It's where CRNAs, are sort of certified registered nurse anesthetists, are being put into play a little bit more, like in an individual setting, is so patients, the hospital, etc., everyone else is getting billed less for the work that these CRNAs are doing, and then CRNAs are lobbying against like anesthesiologists because anesthesiologists are utilizing like different anesthesia assistant teams. So if you guys don't know what anesthesia assistants are, is they work under medical supervision where CRNAs can do individual practice work. So like in more rural settings, and for a rural setting, that's really a factor where it can provide an advantage for the patient and the facility. These rural settings can pay less for these anesthesia providers and have them essentially function as an individual person, compared to an anesthesia care team where these CRNAs and anesthesiology assistants work under the MD. And what they're essentially trying to do is, if you guys are familiar with LVNs and RNs, LVNs are licensed vocational nurses. They work under RNs, and anesthesiology assistants are similar to that, and they work under the MDs. The MDs want job security, and they want their jobs to not essentially not go away and be phased out by CRNAs. So they're lobbying for these anesthesiology assistants to gain more practice in more states, so they can essentially work under the anesthesiology assistants and not let the CRNAs take over, if you know what I mean. But where I think we have to make a difference is advocate for the patient, and for those rural patients especially, where this can really lessen the cost of healthcare, incorporating different professionals. And it doesn't have to be a one size fits all situation. It could be a combination of stuff. But yeah. So I want to go into something else. Is there currently anything that you guys are utilizing the summer for, like anything research wise or creativity wise? I know I mentioned diversity CRNA before with the panels and the intubation like work sim labs. Is there anything else you guys want to add?
Honestly, this summer I'm planning on studying for my MCAT, and just focusing on that. But hopefully, I'm open to opportunities, so hopefully more opportunities come my way.
What about you, Prabhnoor?
This summer I put my 2 weeks in at the pharmacy I work at because my school starts in July 15th, and then I guess it's just time to chill out for a little bit before I start school in July 15th because it's 3 years, not too much of a break. It's like 2 weeks off every single year, which is practically nothing. So it's just, I guess, time to relax a little bit, but I'll go
Yeah,
with some
definitely,
friends.
definitely
So
time to
yeah.
relax. That's one thing where it's like, you're going to be going into these professional fields. You're like, oh, what can I do to get ahead? And then all of a sudden you're like, oh, maybe I should have taken it more easy. But Ravleen was mentioning before how you were really ahead in your education. Could you explain about that a little bit?
So yeah, I did my undergrad in 2.5 years, uh, doing all my pre-med and like all those requirements. So practically didn't have a break from 2021. So August of 2021 all the way through December of 2023. I had no time off, even like winters. I guess just winter break, which was like a couple of weeks. But I did a whole bunch of community college classes during the summers because like UC Merced, they won't allow you to take they won't allow for a concurrent enrollment with the community college unless you get it approved, which is 1 unit. But I loaded up on a whole bunch of classes every single summer at these community college. So all my GEs, my first semester, like I said, I was pre-med, so I did, 4 STEM classes. So I did like Chem 2, I did Chem 2 is General Chemistry 1. I did Contemporary Biology, which is like an introductory biology class for like bio majors. I did Calc 1, which I ended up dropping and replacing with Pre-Calc because of how hard it was. And then I did Public Health 1, which it wasn't, I guess it was a STEM class too, but it was doable. And then after that, I realized that I don't want to suffer. I guess I did end up suffering at the end, anyways, but I got through it. But I didn't want to, have to worry about, the oversaturated amount of classes, like with like a bio major and, all these prereqs. And if you want to take like an upper division bio class, you have to do like 5 prereqs underneath. Whereas public health, like the major classes, you could take, major. I normally did 2 major classes, 2 of my pre-med or pre-health classes, and all that type of stuff. And summers, I just do all the GEs because I didn't come in with any units during undergrad, so I came in with 0 units right out of high school, and then basically just loading up on history and sociology and all these classes during summer. Um, I guess it's a good way to save money because you wouldn't want to take your GEs at UC or CSU where you're paying if you don't get any aid, where you're paying like upwards of $30,000 a year, $9,000 every single semester, which it's a lot of money. And then so I guess it's just smart to play it out that way, where you're doing your GEs at community colleges because they don't really. I guess they do hold a weight, but they don't really hold a weight when you apply to like these professional programs because they mostly want to see your prereq classes. Like, they don't even care if you're a Spanish major and applying to med school, right? They want to see your prereq classes and they want to see your extracurriculars and all that type of stuff. So a big decision for me was also, I need time to do extracurriculars, volunteer at the local, hospitals, and make time for friends. And, and like we started the Jakarta chapter at Merced, so like that took a whole bunch of time, and then being a part of SSA and BIPSHE and all that type of stuff. I guess you needed time, and I couldn't really see myself having time as a bio major because I was like, I don't need virology or I don't need embryology for anything. So why am I going to take these classes that I'm not even interested in? So I just basically also fighting with the institution a lot. Not fighting, but having all these petitions approved to take 20 units, to take 24 units. Like my last semester, I took 28 units to like get out of there as fast as possible. And I don't know why I did it. It just felt right at that time. I could have spent 3 years there and still had a blast, but I guess I didn't. It worked out at the end of the day.
Yeah. It's all about that delayed gratification. You're glad that you did it, and now you don't have to go through it again. Something similar with my friend, I pretty much helped her get a semester ahead in our nursing program, and we pretty much did that through coordinating with, talking with these counselors and having them give you ad codes and just letting you bypass classes, because there's some things that you're not allowed to register for unless you've done other classes. And it feels political because it feels like a way to keep you in college to get more tuition. But I like that you mentioned the tuition aspect as well, because if you don't have any family support or any background support, it could be really costly, and especially medical school, where you have like this 6-figure debt under your name, and then you're just going into residency making like pennies on the dollar. It's something that you really have to be passionate about and really be sure that that's what you want to do. There have been stories of some friends that told me that they went to like certain states so they could do like a program for their medical studies. I know some medical schools in Georgia that only accept people from Georgia. So there's like programs like that where it's also beneficial and it helps you get in-state tuition and stuff like that. But yeah, that's something that's really you have to really be wary of. And also, Ravleen, you mentioned how you were studying for the MCAT. Is there anything in specific that you're looking at, like resources wise, just so our viewers can also look at those and if they want to study for the MCAT?
So I did get access because UC Merced was able to give me a huge discount. I got the Kaplan books for like, I think $200, and their whole MCAT program. And then also I've been like listening to a lot of other people before me taking the practice exams. Prabhnoor, I forgot what the website is, but
AAMC.
Yeah, that one. And honestly,
there's also Magoosh, I believe, Magoosh or something.
Yeah,
and I know that one's really good as well. Go ahead.
But yeah, just like honestly, I've been asking everyone. That's something that I found hard, was like reaching out for help. Because I am first generation and like the oldest, and I feel like if I did ask for help, it was me being like vulnerable, and that was something that I didn't want to show the world. But as like, for me, like I didn't have like a guide. Like I wish I did what Prabhnoor did. But I did end up being a biology major, going through all that hassle, taking embryology and all those like extra classes. And then one thing I did learn is like, don't listen to your counselors, because, they want you to stay there, and then they want your money. And I had a roommate who she's going to veterinary school at Davis now, but she transferred out because Merced wouldn't let her change her major. She wanted to change it to biology. Like, oh, like you can't change it. And it was a very dumb like reason that they were giving her. So she transferred out to SF State, and I'm so glad she did, because she found her way. Now she's going to veterinary school. It took her, yeah. But I think the number one advice that I would give like undergrads now is don't listen to your counselor.
Yeah, I guess I can't emphasize that more enough. Don't listen to your advisors. I helped a whole bunch of freshmen out, the incoming freshmen. So I was a senior, and I was like, the community outreach chair for a couple of the organizations I was a part of. And, I helped probably like more than like 15, 16 of them made their plans. Like I didn't have any STEM classes left my last semester, so I was free. And, public health classes are hard, but it's like, you could study. It's nothing compared to, like biology classes, which are more content based, like content heavy. But they were hard, and I helped a whole bunch of freshmen out making their plans, finding these double dipper classes that would fill two requirements. And I never met with my advisor. I don't know. I guess I overpassed it every single time. I'd like just send them an email saying I can't make it, or like please remove this hold, because I knew that they wouldn't be able to help me out, and all they wanted was to make money off of me. They're profiting from me staying there, and like I didn't even tell them that I was gonna file for graduation my last semester. I just did it because I was like, I'm just gonna file for graduation, and if they want to approve it, they will, because they have no choice not other than to not other than to approve the application for graduation. But I guess don't listen to your advisors. If you find upperclassmen, connections matter a whole bunch. My first semester, I guess I wouldn't. During undergrad, I was 17, and so first time out of the house after COVID. You didn't really have a senior year during high school, so I was like, okay, what the hell, I'm just thrown out here in like a school with 9,000 kids, so much freedom. My parents aren't breathing down my neck. Like, what do I do? I was like, this is my time. You could either make use of it, or you could, not make use of it, if that makes sense. Like, you're at the end of the day, fun is important, but you're there to go to school. I sound like my dad right now, but fun is important, but you're there to go to school, So make use of it. Don't be a super senior. It's okay to be a super senior because everybody runs on their time, but don't waste your time paying these institutions so much money for just failing a class because you went to X amount too many parties that semester and you couldn't really pass the exams. It's happened to a lot of our mutual friends that if they're out of freedom, they have so much freedom that they ruin their time, and they're like, oh, they dropped out of the semester and their parents don't even know they dropped out, or so I guess it's just like, focus on what you're actually there to do. Fun is important, but don't let fun come in the way of you and your success, and don't listen to your advisors. Make connections with upperclassmen, make connection with these professors. I made a connection with the impossible professor. He was super hard, and his class was horrible. He was not horrible. His class was hard because he wanted people to, realize like, oh, this is the second bio class he took. So he made it hard on purpose, right? I was thankful for that because, like he basically would weed people out. Like this is how intense this class is. Like if you can't pass my class, you're not going to be able to pass the next class up. Like you're not going to be able to pass cellular biology. You're not going to be able to pass virology and all that type of stuff. And people hated him for how hard he made an introductory bio class. But then at the end of the day, I made a connection with him and I talked to him like, hey, why are you doing this? And it all ended up making sense. And, for listening to his tactics and listening to what he actually expected out of students, like, don't be intimidated of your professors. Go up to them after class, meet with them during your office hours because they want to help you, And I'm super glad I went to UC Merced rather than I was considering UC Riverside over Merced. And I'm super glad I went to Merced because they had that, public university. It was a public university with that private school vibe. Because the enrollment now, it's doubled or tripled. It's gone up a huge amount. They went from 9,000 my first semester to like 24,000 kids my last semester. So they've expanded their enrollment a lot, and it's, getting that UC sense of people not being able to get into their classes and people, having to be on the wait list and all that type of stuff. Like there wasn't even a wait list for. Like that's how easy it was to get into classes because there was no wait list. They introduced a wait list my last semester because they like expected their enrollment to roll up, amp up, but connections are important. I'd give pre-med any student, just make your connections, talk with your professors, go to those clubs. You're not going to get along with everybody. I've been through it. Like people are going to part ways. Don't hold on to it. It's college. Like you're making your choice, they're making their choices. At the end of like, just move on. If you're having a problem with someone that's not high school, just move on. Like get over it. It'll take a couple of days. Get over it. If so connections are important. Focus on your school. Don't waste your time is important. Don't waste your time going to like these parties, or don't waste your time being involved in like all this stuff going on the side. Like focus on school, get those connections, and your GPA matters a lot. Like your GPA matters a shitload. If you would say like a major factor of like your grad applications or your professional applications is your GPA, and get out of there. Don't listen to those counselors, like Ravleen said. Like, figure it out yourself.
Yeah.
That's something I really like about our people as well, because we're more constructive in that manner. We're like we usually like tend to see the path, and then we're like, oh, how could I like figure out a puzzle to like make this work? Which if a counselor again has to go through so many students, they don't really have time to personalize everything for you. So you kind of have to take that initiative. And I like how you mentioned that as well, the UC Riverside aspect of it. Actually, out of high school, I got into CSU Fullerton's like direct entry nursing program. I would have been done like way earlier, way sooner, but I realized that like going to Fresno State's nursing program is beneficial for me, like in terms of my growth as well. The reason I didn't end up going to the direct entry program at Fullerton was because of the COVID era. We had no idea if our classes were going to be in person or online, and they were seeming like they were going to be online. And I really didn't want to pay for college for the first 2 years when I knew it was going to be online education. That just seemed really cheap. I wish they would have like either decreased their tuition prices, or had some mandates to make it in person. But that's something you have to be wary of. You have to look at your own circumstances and like work with what you have in that regard. If I were to go back and tell a student something, is would be to definitely join the Fresno. If you're in Fresno and you're applying to Fresno State, join Fresno State's SMIT Camp program, because with SMIT Camp, they let you register for classes before anyone else does, and you get the preferred clinical instructor you want. You get your classes that you want. You get everything. Nursing students get the classes that they need anyways, but where it's beneficial is if you need to take other graduate school classes, or if you need to, let's say, if you want a clinical instructor that's easier, and then you can get that clinical instructor in that way. One thing that I'll mention is that this summer, or actually this Monday, I just got reminded of it again, is my 3-week organic chemistry class that I have to take. And so I'm just gonna lock in for those 3 weeks. No podcasting during those 3 weeks. And then just focus on that. I'll obviously do what Prabhnoor did and get ahead if you can.
Yeah.
It seems like your parents raised you well, because you went away, right, to college, and now you're doing all the things that they wanted you to do. So their teachings work, man. It's like it's all uphill from here. You're in your program. You guys are doing great. But yeah, we'll end it off here. If you guys have any last statements to say.
Honestly, thank you for having us. This is actually a really cool like idea. It's a nice opportunity, and just like for everyone, connections are important. Like Prabhnoor said, go out there, don't be shy, like reach out to people.
I guess dual enrollment. Listen to your parents. We don't want to listen to our parents most of the times, because we're like, oh, you guys don't know anything about the system. But listen to your parents. I guess if I didn't listen to them, or if I wasn't, I guess, scared of them in a sense, I probably wouldn't be where I am today. But yeah, I guess thank you for having us. I enjoyed this, and I enjoyed, the whole experience, so I appreciate it.
Thank you so much. And yeah, that's it. That's it for the Colorful Scrubs podcast.